So in this session, a very, very contemporary, timely, and relevant session on digital health policy, I want to introduce Professor Lisa Levitt. She is a healthcare expert and futurist with a specialty in digital health strategy and operations. Advocating to improve healthcare quality and cost, she helps integrate face-to-face and virtual services. She generates momentum for change with people, data, and technology. Nationally, Ms. Levitt has worked with leading vendors, insurers, hospitals, and medical groups in various markets across the United States. These employers and partners have included Harvard Hospitals, McKesson, Teladoc, Blue Shield of California, Adventist Health, Avizia/Carina Health, and Molina Healthcare. The diverse patients and customers for these offerings have included multicultural communities along the economic spectrum, from the wealthy employed to the homeless people. Currently, Ms. Levitt holds several roles as an industry consultant and academic. She is founder and principal of Panorama Health LLC, a consulting firm specialized in digital health planning, implementation, and messaging. At the University of California, Irvine, Ms. Levitt is a member of the Institute for Future Health. Through the Paul Mirage School of Business, she enjoys teaching MBA, undergraduate, and executive education programs. Topics include digital health in the future, US healthcare system, global healthcare systems, business data management, and the business of medicine. Her courses emphasize cross-functional collaboration among students and from diverse backgrounds and disciplines. Welcome, Professor Levitt.
Thank you so much. It's great to be here. I think it's a little ironic that my backdrop is very not digital, but I do love books. So here I am in my professor house. So I'm thrilled to be back with you. It was exciting to be part of the inaugural School of Medicine Health Policy program last year. And when I was updating my deck, I realized how much has happened in a year. I mean, already in April of 2020, the pandemic was underway, and some of the trends I'll be discussing had already started to take off, but I think we all have a broader and maybe a more sober perspective over a year into this healthcare evolution, really. So here's our agenda for today. And I will, just to level set, describe digital health services. I'll talk about how policies are shaped by the different constituents. We will go over key components of policy from both government and private sector forces. I will recap the massive impact that COVID-19 and the pandemic has had on patterns of practice and patterns of consumption of healthcare services. And I will leave you at the end with some key resources. And one of the things that I love about digital health, as Kelly said, it's alive and a very dynamic arena. So I really encourage you not to look at this as something that you hear about from a distance, but invite you to join the dialogue, because I think what digital health is going to mean for our healthcare system is still to be determined, and we need more voices at the table. So just to sum up the map here, the healthcare industry, of course, is complex. There's many factors, and I'll be explaining why digital health matters and what factors have affected the pace of change. So I know you guys have had a broad agenda already for over a week, and digital health interacts with all of these factors. So to sum up, what is digital health? And also a common question, what is telehealth versus telemedicine? I'll explain that digital health is really an umbrella, and then there's key categories underneath it. I would say telehealth was the precursor, and then digital health has grown up and around to include telehealth. So many people during the pandemic have been focused on the real-time live consults from a distance, which of course have created a lot of safety for both the providers and the patients. What I also want to draw your attention to right underneath is asynchronous interactions. And especially for those of you in training now or just launching your careers, I think that the role of asynchronous is ultimately going to lead your practice of medicine to look very different than even 10 years ago, because you come in with different digital skills and habits and expectations, and the technology keeps growing in terms of what can be done and how people are willing to engage with their health online. Remote patient monitoring at the top of the other column involves ongoing interactions at a distance. So asynchronous tends to be more episodic, but it also is a component of the remote monitoring where someone is in relationship with a provider and they've agreed on usually what their risk factor is or what disease or condition they have been treated for that requires monitoring. And mobile health is a subcategory. More and more, like the rest of our lives, mobile devices are part of healthcare, but it has grown up as a separate category. And similar, again, to other technologies, the tools keep shrinking smaller and smaller. If you look back, not even 5 years ago, telehealth used to involve very large carts and machinery that had to be in its own separate room or locked in a closet for safety. And now a lot of major hospitals, especially during the COVID explosion of telehealth on short notice, people are able now to just have stations with iPads, et cetera. So the investment in terms of telehealth has really shifted from a infrastructure standpoint. So this next slide, really some of the materials here are late breaking. This was just published a few weeks ago. And I'll give more tribute in a little bit, but it's by a finance institution actually that has been working in digital health since the 90s. And just going quickly around the circle, their version of the ecosystem includes the triage and intake digital front door, which is a phrase you'll hear, virtual visits. The provider to provider component is really exciting. I think may bring a lot of practitioners back to their roots of why they went into medicine. All the great training in medical school, consulting with colleagues can now be done electronically. It has really opened up horizons for primary care physicians, which is huge. Some of you may have heard of Project Echo, which was founded at the University of New Mexico, where specialists are giving tailored information to the primary care physicians through originally Zoom, through platforms now. And it's really expanded appropriate scope of practice for primary care physicians, giving their patients more access and continuity of care. Then there is virtual second opinions, which is related to the e-consults. Telepharmacy is growing. Clinical, just general clinical communications, in-home monitoring, we talked about. Digital therapeutics and self-care is really important now. So one of the thought leaders who I admire, Jane Sarasone-Kahn, has been talking a lot about the home as hub. Obviously, many of us, due to quarantine, spent a lot of time at home. And so that has shifted how people view their home as a site of care. And in a sense, what's old is new again, because of course, back in the 1800s, turn of the century into the 20th century, there were home visits by doctors. And then everything moved into dedicated clinical environments. And now we're back to being able to engage with patients at their convenience and on their sites. Part of mobile I should have added, which they highlight here, is wearables, and that connects to at-home exams. And this is really exciting in terms of the overlap with consumer electronics, which we'll talk more about. Virtual primary care is its own category. Virtual clinical trials is also very exciting. If you have not thought about that or realized that area is growing. The reason it's important, of course, is when people have to come into a specific site, that creates certain channels of access or lack of access. And it also makes recruiting much, much easier. So I think that all of this can help accelerate and improve the diversity of populations that are involved in clinical trials. I'll just pause. I'm seeing a few things in the chat, so I want to take a quick peek.
Editorial.
Oh, great.
Lisa, just like, you know, I'll just sprinkle, and if people do have questions at any point, I'll just interrupt you. By the way, we are seeing the entirety of your PowerPoint. I don't know if you wanted to be on presenter mode or otherwise.
I actually don't, because then I can't see all this other stuff. Okay. So if it's really hard to see, let me know. But yeah, I have found from a year of remote teaching that if I go into presenter mode, it slows me down to back out and go into polls and things like that.
No problem.
And really glad to hear, Kelly, that you've helped launch ECHO programs. So I'm fortunate to have a little extra time beyond last year's hour time slot. So we'll see if we have room. I'd like to hear from more folks who probably have a lot more experience with digital health than a year ago. So speaking of which, that is a great segue to our polls. And I will put my poll everywhere into the chat. And I'm offering the text option as well. So I'm going to stop sharing here and we can all look at the poll together. Trying to get back to the share button. My Zoom is, it was hiding over there. And I include in these questions, not sure, just because some people do get hung up on definitions, et cetera. So please continue answering. It was funny, actually, about a couple months into the pandemic, I did an informal poll of my mother and her friends. And still there were people early last summer who had not heard of telehealth, and their main questions about it really had to do with money. So whether or not it was covered, paid for. So such is life in the United States healthcare system, where pricing and cost responsibilities can be variable. So I'm seeing that 100% of the people who have responded have tried digital health as a consumer. I know there's sometimes a little bit of a lag, but you guys seem to be pretty fluent in this. And the next question that I'm going to ask has to do with what that experience was like. So I know a number of you are providers yourselves. This is not about your experience as the clinician. That'll be the next set of questions. This is for you as a patient, what you thought. There is a lot of dialogue about this. I mean, one of the interesting things is there's been expansion of policy freedom due to the pandemic and the public health emergency. And then there's many people questioning, should that stay? And so there's a lot of discussion about, are the patients happy with telehealth? Are the providers happy? Is there a difference? So I appreciate your participation here, so we get a feel for it. So far, you guys as patients have been really happy with telehealth, is what I'm seeing. And by the way, I definitely have used telehealth as a patient. I was an early adopter. And there's been a lot of discussion. The CMS definition had originally focused on rural areas. And for over 10 years, I lived in Los Angeles as I got started working in telehealth. And we definitely discussed how there were access issues in urban areas, you know, benignly from traffic and things like that, or worse, just because someone doesn't even have a car and it's tough to get around. All right. And many of you, I'm sure, have dealt with parking at medical buildings, which is not always easy. So now I'm curious how many of you have delivered care digitally as a provider? And once again, the poll information is in the chat. It's different than the other poll that the policy program is using. I'm just a little curious that there's been all 100% yeses on everything. So statistically, that surprises me. Okay, there we go. I had it restricted to registered participants only, so that was skewing it. So about 2/3 have been providers. And we're curious about what you think in terms of your experience virtually. Well, so far, it looks like I can go back and see if we open up on the previous restrictions. It looks like all the patients were happy and all the providers were not, which actually reflects some of what's been, so yeah, 50%. Yeah, even without the restrictions, a lot of happy patients, less happy providers. So that is pretty consistent actually with what I've been seeing in the media and on my LinkedIn feed. So thank you guys. I appreciate the input there. It's always good to know kind of the tone of the audience. And I can go into presentation mode from here out, actually, if that will help. So the main point here is people like to debate. It's kind of like tomato, tomato, telehealth versus telemedicine. And it's still a very young field. I wouldn't even say we've reached adolescence because of the continual expansion of types of tools. So don't get too attached to the definitions. There's always a role for marketing teams who will claim certain terms or define them in their own ways, et.cetera. So now let's talk about a few key milestones for digital health and policy. Does anyone have any thoughts on how telehealth is different from other medical technology? So when you think about digital health, whether you can differentiate that from other types of tools that you would use for your practice of medicine. And I'll give you a hint. I already touched on it a little bit earlier. There's the chat. It was hiding. I'm not seeing anything popping up in the chat. So if you have other thoughts, let us know. My main point is that digital health has expanded much more into the consumer realm and even grown from the consumer realm. So when Kelly put in the chat earlier, shouting out to her Apple Watch, there's been a whole different regulatory path for these types of tools that were launched in commercially versus those that were designed upfront to be kind of clinical grade tools. And so just keep that in mind as we talk about the evolution of the field. So even the telephone, televisions, computers, mobile devices, things that are part of everyday lives were not regulated this way. And so a lot of the assumptions or the foundations of healthcare practice and policy were not designed to include the technology that we're actually using now. I just learned, actually, there was a special interview with Dr. Sanders recently, who is known as the father of telehealth. And he actually, if you look at the interview with him, he gives credit to his mentor, Dr. Bird, who was so frustrated with traffic in Boston when he had to go back and forth to support caring for sick people who had urgent situations at Logan Airport, that he was the one who said, why don't I just put a television in Mass General and at Logan, and I don't have to drive back and forth. And Dr. Sanders was funny. He said, I thought that was a crazy idea. And ever since, I've been working on Dr. Bird's crazy idea. So here we are. This is the infographic that you can look at later if you'd like, which speaks about different milestones in terms of course, adding internet made a big difference. Many people are still debating the value of pure audio interactions. So adding internet, getting high-speed capabilities to have live video has made a huge difference, even though, as we saw in the poll, many clinicians may still not be comfortable. There's also differentiators between diagnostic visits versus care for patients who already have a diagnosis, and it's more of a follow-up situation. So people like to ask, particularly outside the healthcare system, why is this evolution so slow? Because here we're looking at payment. So there's the evolution of the tools, and then there's the evolution of payment policies and fee schedules, basically. So right around the time that the internet was becoming more mainstream in the mid-90s, here in California, the state began to regulate payment and provision of telemedicine services. It was only at the turn of the century that Medicare approved it. And of course, Medicare is the huge bellwether that will create tipping points. But again, as I mentioned, rural only. And that has been a severe limitation. There's a calculator online that they had that you could type in zip codes to see who qualified. And that also meant that for grants, which started to be available, that you often had to be serving a rural population. The Ryan Haight Online Pharmacy Act, for anyone who doesn't know, was created to protect consumers because a young man, Ryan Haight, was able to order drugs, pharmaceuticals without a prescription online and basically overdosed and died. And therefore, it created a lot of restrictions that have actually become problematic now that we are trying to address the opioid epidemic. So there's a lot of nuances, again, of context and situations. And 2019, California passed a parity law for all our insurance payers licensed in the state, that you have to pay the same amount for care provided online as in a face-to-face office visit. And parity, I will say, makes a big difference from a provider standpoint. Obviously, people are less likely to adopt telehealth if they feel that it's going to undermine financial compensation to them the same amount of time that they're putting in. And also, when we look at the health economics, I always like to say, the reason I'm very interested in asynchronous care is if we just take all the healthcare that's happening now and move it online, we still have the same amount of providers, we still have the same amount of time, and then with parity, we still have the same amount of money. So when we look at the big picture of United States being roughly twice the cost of gross domestic product on healthcare than other developed countries, telehealth has not really solved, is not contributing to the solution on that problem. So I think you probably have heard that saying, necessity the mother of invention. And before COVID-19, there really was very limited perception of necessity. I would argue that there were a lot of people who were not getting served well by our health system, who just maybe didn't have a voice. So again, people who might be in medical desert areas, people who may feel intimidated walking into medical office buildings, or more limited in choice of interpreters once they arrive. All of that is much more flexible, but it wasn't creating a sense of urgency. And I will say one of my favorite memes that came out in 2020 was a multiple choice question: who is driving technical transformation at your company? And answer A was CEO, answer B was CIO, Chief Information Officer, and answer C was COVID-19. So as you're probably well aware, that was the jetpack fuel. So the reality is, shifting to digital health involves taking a fresh look at a lot of our assumptions, our fundamental approach to delivery of care. And there are some sacred cows, which have been part of why it's been so slow. I would even call it threatening. Whoops, jumped ahead there. Some people feel like they were only trained face-to-face, so it's hard to imagine quality care. And for those of you who are having a worse experience, I'm not going to question or invalidate that. There are best practices for telehealth. In the haste to expand in COVID, I don't think everybody maybe received full training, but all of that is possible to optimize, and there always will be patient populations that I don't think it's appropriate for. And definitely in the beginning, the people who started out using telehealth, not many people know astronauts. By definition, rural people, may come into less contact with people in their day-to-day life, American Indian or Native American reservations, et cetera. So it was really a niche service in the beginning. And I think all of us in healthcare are always concerned about risk. Hippocratic oath, first do no harm, means that people tend to maybe look at what could go wrong instead of the larger opportunity of what could go right or improve. So there's a lot of opportunity in terms of who gets to interact in new ways. So we talked about on the category of business to business, clinicians to other clinicians. I met a lovely woman, an eye doctor, who actually created a really popular app because she was on call for emergency room support, and her schedule and the emergency room doctors never matched up. And she finally just said to her brother, can you make me an app so they can send me a photo of the eye, and I can tell them really quickly some basic triage from my expertise, and we can all keep the rest of our day and evening going. So I think that's just a reality for clinicians to collaborate. The digital tools are really helpful. Obviously, there's a lot of discussion about business to consumer, patient care. But what I want to highlight is this bottom section. And I really liked this quote. Jane Saracone-Kahn passed it along in a recent article, but it goes back to June 2004, where Dr. Safran pointed out that patients are actually a really underutilized resource, even though they are the ones who have the most at stake, obviously, in their own care and their own health. And I agree that patients want to be involved and that their participation will lead to better medical outcomes because they're engaged. They're not being passive about it. And the digital tools open up a huge world in terms of interacting with the provider, but I would argue also self-awareness. So all the remote monitoring tools, et cetera, it's not like the blood pressure cuff or the scale that has a Bluetooth connection or other vital signs are just sent to the doctor and the patient remains blind. The patient gets to see, probably for the first time, accurate, consistent tracking of what's happening in their body. And especially with chronic disease, there's a huge connection between how am I sleeping versus what did I eat versus what's my weight or other characteristics. And I think that that's dialogue. I'm more of a public health person, so I've always believed health is what you do every day. But I think in other sectors of the healthcare industry, that piece has been missing or downplayed. So let's look. Well, I'll pause there. Are there any questions so far?
I haven't seen any questions come in yet.
That's great. Thanks. So we can move forward then to who regulates digital health. And the thing to understand is there's a lot of layers: federal government, state, the medical societies and industry associations have all kinds of guidelines now more than ever. And they interact with what's allowed at state. So obviously, someone could lose their license, which is a medical industry issue versus state government, and then the private insurers as well. I definitely want to draw your attention to the Center for Connected Health Policy. It's very timely. Just this week, they rolled out a refresh of their website. It is a huge leap forward. I was kind of giggling because I used to have to, or I had the opportunity to help my clients with regulatory interpretation. And as CCHP pointed out, they used to do a refresh on their 50-state review only every 6 months. And obviously, in the middle of the current healthcare emergency and the spotlight on telehealth, that was way too slow. So they have formally just launched a interactive tool that you can research, it's searchable, you can look up different states, et cetera, and they are committed to updating that real time. So I think that's great and critically important. So their framework for how health policy is defined for telehealth is number one, what specific services are eligible. Then who can be reimbursed? So, and you can kind of look at this as a matrix. So what services are counted in the state or like Medicaid program for telehealth? Who is allowed to do that service and get the reimbursement? There's a lot of focus on where the patient can be, not so much the provider, but I got stuck in some states before COVID because they had restrictions that patient had to be in a clinic or at a school or someplace that was deemed appropriate for someone to be having a private interaction about their health. And then also, how is the service being delivered, as in which modality? And so that includes video, voice, and asynchronous typically. So this unpacks it a little bit more. So there's more around the licensing of the provider, and the big breakthrough. I mean, when COVID first hit, I should say there was also, for the first time, granting legitimacy to non-HIPAA compliant communications. So a lot of provider organizations said, you know what, it's okay to use FaceTime, Skype, et cetera, that did not have the layer of HIPAA security. And that was a really big deal. And here's just a snapshot going back to 2017 as to who covered for telehealth. So the blue is Medicaid and private payer, orange is Medicaid only, and blue is private payer only. And CCHP says 50 states, 50 approaches. There is not a lot of consistency. It has been confusing, and some bills to change or expand telehealth coverage would languish for months or even longer than a year. I would be tracking it with my clients, and it was supposed to have a hearing, but they didn't, or they were in a feedback period and then they were integrating the feedback. So again, COVID really gave people more focus and urgency. And thank you, Kelly, in the chat for defining medical desert. That's an important term. So now what's going on with telehealth and digital health? It's been a very dramatic shift, all of the temporary flexibility. And I think what was the great shock for those of us who had been advocating for telehealth from before COVID was what a difference it made to have the providers really seeing the benefit, even if unwillingly, but knowing that they would be at risk if they were seeing patients who were diagnosed or who could be incubating the disease. So this was the first time that there was a medical advantage over in-person care. Although there had been more and more, I mean, as we've had unfortunate earthquakes, hurricanes, et cetera, natural disasters, there was a number of telehealth companies offering pro bono services as a community service. But COVID really was the breakthrough. So the next slide is a lot of text, just to give you some context that there was a weekly increase in telemedicine visits. This is from a JAMA research letter. I've been very fascinated by the way of how the academic journals have been working with speed of information. So instead of doing a full article, they did a research letter. And you can see we're still not talking massive volume total. The percentages are very impressive, but that's because it was so low before. So there used to be less than one visit per 1,000 enrollee, which translates to over 2,000% change. And simultaneously, there was the drop of 30% in face-to-face visits. Here's a visual for you from the article, which charts the total visit line is gray. The in-person visits are black, so you can see that massive drop off. And then the rise a little bit again. And this is the week in 2020. So this is the first 24 weeks, so roughly 6 months. And then here's telehealth. So you can see it started out so tiny and then came the surge up as the in-person visits came down, and then it's tapered off a little bit. And there's a lot of kind of people placing bets on what where all this is going to even out to as hopefully the spread of COVID calms down and it's safer to do more activities of normal life. And we know there's a huge backlog of care that people have not been accessing. And I think there's a lot of smart, creative minds looking at what should be done face-to-face versus what has flexibility to be online. So claim lines, it refers to insurance claims for telehealth. In August of 2019 to 2020, increase of, again, that thousands of percentage points, because the original was, not even 0.25% to just over 6% a year later. And this was consistent across all regions of the United States. Here are a couple of resources for you. I'm a big fan of the Center for Connected Health Policy, as mentioned. So they have a lot of coverage policy specific to COVID, general resources. And then this is an infographic. I will see if I can get to that one quickly. Yeah, there it is. So I'm going to switch over just to give you a feel for that. They did a really nice job. So at this point, 50 states and the District of Columbia all have defined telehealth, telemedicine, or both. And by the way, there's crazy stuff out there. I've seen some states where like telemedicine is if you're a doctor, telehealth is if you're a nurse. I mean, again, kind of creative and makes for confusion. All 50 states are now, the Medicaid are reimbursing for live video. SNF stands for store and forward. So 22 of the Medicaid programs will include that asynchronous interaction where someone can send a diagnostic scan, lab result, et cetera. 26 of the 50 states and DC reimburse for remote patient monitoring. 15 states allow audio only service delivery, which has been a big discussion in terms of social determinants of health, equity, and access, because people with less money tend to have less fancy phones, and also less robust data plans on their phones. So that is a concern when you eliminate audio only. So again, it's kind of balancing perhaps some clinicians' ideal of wanting to mimic face-to-face as much as possible versus literally someone just not getting care. And I really would emphasize there are a number of people who have just not been interacting with the system, who I personally would like to see engaged in getting appropriate care, and that this could be a first step for them. 26 states in DC now reimburse services to the home. So that's, again, where the patient is. And 27 are offering services in the school-based setting, which was not so useful when schools were closed because of the epidemic. So this really is late-breaking information from this spring. And thank you, Kelly, for pointing out that the infographic also is linked in the syllabus. All right. So coming back to the deck, there are a whole bunch of people who have been trying to boost telehealth for many years. And the theme, even though we were sad about obviously the terrible impact of COVID on people's health and mortality, it was a feeling of, at last, wow, this is finally happening. I even was at a conference where a physician leader spoke about the rise of telehealth at her specialty hospital. And she opened her talk by saying, well, of course, like all of us, when the pandemic began, I had no idea what telehealth was. And my heart sort of sank. I mean, it was representative of why the adoption was so slow, but there really were people who knew nothing about it when the pandemic started. There is a lot of, as I mentioned, concerns of what could go wrong for quality of care, waste, that people go for telehealth, but they still go for the in-person visit later, abuse and fraud. that the care didn't actually happen, or the coding, it was upcoded, or meaning that people charged for more expensive care than occurred, et cetera. And interestingly, another colleague of mine, Dr. Yael Harris, just published a paper analyzing, I think, pretty recent information about telehealth utilization and claims from the COVID era, and found that fraud was not a significant problem, or at least not more than it is in regular healthcare, which it is an unfortunate part of our healthcare environment. So I am not seeing more questions, so I'm going to keep chugging through, and there is room for questions at the end. The thing that is exciting for me as a futurist is the opportunity to redefine delivery of care. And I would say that the system that we're in was designed for a different population, for a different context of lifestyle, and this emphasis on the synchronous office visit during office hours, where clinician and patient are together at the same time. And the preference of providers who work together on a team wanting to be in the same office or city. So there were communities of providers, which again is a lot of benefit both for the providers and the patient, but it has limitations when you have provider shortages. The focus on the physical exam, data captured solely by the clinical team, and I would add even maybe only viewed by the clinical team, preventive versus acute care, public health population view versus individual care. And so what's possible now through digital health is the asynchronous communication, dialogue outside of Monday through Friday, 9 to 5. So you can do things with people in other time zones, et cetera. People may not want to hear it, but there are some providers that are being set up as bots. And there's been some data that, especially with the current mental health epidemic, that some people are receiving comfort and useful guidance from automated interactions. And we all know there's just not enough mental health practitioners to go around. So I think there's, again, maybe the difference between the ideal and the real of what we're trying to work with on a population health level. Some providers and their patients may never meet. That happened to me with one provider. I think I met her a year or two after we started doing care. And for me, it wasn't a barrier. I know not everybody feels that way. And so this idea of patient-centered care, you may have heard of, really digitally, that is a reality that the clinical teams can organize around the patient. They don't have to be co-located. There's a rising interest in integration of care, physical and mental health, and those teams can now span across geographies. A lot of opportunities to supplement diagnosis with algorithms, artificial intelligence. Data can be captured by the clinical team, can become brought from a third party or the patient. And I think that that really opens up a more 360-degree view of the patient. It's not the patient coming in who you haven't seen in 6 months, and the patient is reconstructing their memory of their health when they're not really trained usually to track their health objectively. And then interpretation can be by the provider, by the algorithm, or the patient. So I'm curious, we can pause here and I'll take a drink of water as well. What do you see as current issues with in-person delivery of care, and where could digital health perhaps improve the care of patients, both preventive or through the acute spectrum of care?
And to be clear, is this on poll or just free response in the chat box? Or on
Free response in the chat.
Okay.
Thanks for checking.
Well, I could certainly mention, just to kick us off, one of the issues that digital health has actually solved is physical access. Physically getting yourself into an office takes a tremendous effort for some people, even people with means and resources. I was most frustrated interacting with elderly, less tech savvy folks in the digital health space, but realize that they also might encounter some of the greatest physical barriers and transportation barriers. Even walking from, parking lot to office door is a lift, right?
Yeah, those are great points, Kelly. And I had the personal experience. My late father had Parkinson's, and in the last 2 years of his life required a wheelchair. So I was really excited to read about the current study by the Michael J. Fox Foundation, where they found that follow-up visits for Parkinson's were equally effective face-to-face or online. And I mean, it was like a 2-hour ordeal, which my father didn't particularly enjoy, to get into the wheelchair and all the way to the doctor's office for like a 10-minute visit and come all the way home again.
So what are other people's thoughts? And this is certainly could be a hypothesizing, that's not a verb, but a what if question for some of our pre-medical students that haven't actually engaged in care delivery. What do you perceive, maybe as a patient yourself or as a caregiver, of some issues with how we deliver care in person? And you can also zoom out. We learned a lot about our system, right? So you can tell us what issues exist that digital health could solve.
Thank you, Kelly. That's a great way to frame it. There's a whole arena called design thinking, which it has to do with empathy and putting yourself in the shoes of your user of a device or whoever you're delivering services to. So yeah, even if you're very early in your medical training, you've probably, or you or your family or friends have been receiving care all along.
Okay, so I personally got cost. You mentioned how it doesn't solve everything in terms of our quadruple aim of delivering quality care at lower costs, etc. But I think cost is certainly a barrier. So thank you for that person that messaged me. We could unpack that a bit to say that it could either be cost of the system, you have to pay an entire front office staff to manage an in-person health system of care, while you might not necessarily need all those people in a digital space. The cost to the patient in getting themselves there, copays might be exactly the same depending on how you're accessing your provider. But I think cost is certainly an issue. Great. Joanna offered less waiting room time. So that waiting room time would be the current issue in-person delivery of care, and patients can just wait in the comfort of their own home instead. So instead of sitting in a sterile armchair, you're sitting in bed, right? Waiting for your provider to turn on to Zoom. Sure, Joanna.
Yeah, thank you. I want to mention also, there were some really lovely speakers and articles. I noticed it was a little bit more from the pediatric specialty, but for example, doctors who had been seeing, a doctor said he had been seeing a young man for, 6-7 years. So age 5 into adolescence. And the kid was not very chatty during the office visits. And then after the pandemic, the doctor got to see the patient who was now at home on Zoom and found that the patient was more forthcoming. And he had a habit as a doctor to ask patients if they wanted to show him around the space. And so he, like this young man and other patients, would show the doctor things that had some sentimental value to them, or, things that represented hobbies. Oh, this is my soccer ball or something else. And that for those doctors, they found that delivering care in the context of the patient's comfort zone actually increased kind of the depth and the breadth of the interaction. And, I would say that I'm not a doctor, but key to good care and diagnosis is the quality of the information that you're getting from the patient and about the patient. So I thought those were some interesting insights. You can find those online. They've published articles about it, et cetera. The other thing I just wanted to go back to in cost, Kelly, have you guys talked about rising risk from a population health standpoint?
Well, we talked about how shifts in population demographics have increased costs to the system. We've also talked about insurance risk and how they're relatively risk averse. We've talked about underwriting and insurance practices, but I don't know if that's exactly what you're getting at.
I'm actually using risk in a slightly different context, so thanks for that helpful overview. What I mean by rising risk is somebody who's got a predisposition to later developing a negative health condition. So either by their demographics, percentage-wise, they're likely to get a certain disease, or family, genetic predisposition, patterns of incidence, et cetera. So the reason I bring that up is going back to the other person's helpful comment about cost. When you have systems like remote monitoring, if you can engage the people in the rising risk population, then you have a future cost prevented. So right now, acute care, there's not a lot of difference. But it's that idea that if there's an inobtrusive way that someone can be monitoring themselves and their doctor can get a reasonable dashboard, not like deluged with data, which is a concern of a lot of providers, but a way that the system will stratify the patients and give reports to the practitioners to say, hey, this person's blood sugar average just jumped up, or this person has gained weight, that the care team can reach out and engage. And again, it doesn't have to be the doctor, but that someone can be deployed to start to have a conversation, which doesn't have to be an office visit. And the key for all of that comes back to reimbursement. So how do we continue to pay the care team for more like a broader arm's length form of care instead of the office visit, which has always been the key to actually getting a fee. And there are, you guys are probably aware, there's some payment mechanisms that have been bubbling around value-based care, et cetera, where if you look at the population health, providers would be paid for categories of disease or overall population health indicators. So just planting some seeds there. So we're in the home stretch of the slides here, and I'm definitely open to other general questions. So in terms of the future, which is where I like to live, at this stage with finance industry, do people really make a distinction between online banking versus regular banking? You just deposit your check. It happens to be through your phone now for many people. So there's a lot of us who think digital health will simply start to be folded into the umbrella of healthcare. This probably will take a longer time just because of the nature of healthcare and the environment. And some apps and other components of digital health may stay separate. And I mean, I think there's a lot bubbling, not only in terms of health policy, but in terms of legal definitions of healthcare, who's a provider. And I will say, by the way, those of you going through medical training may end up working for digital health companies, either as, you know, could be 100% of your career, you could keep practicing medicine, but be more in an advisory role or a split role of some business management and some patient care. But there's a lot of people obviously interested in healthcare because it's just a huge market, and they don't always know a lot about healthcare. They know how to build apps or they know how to market things. So I think there's definitely room for legitimate partnerships with legitimate healthcare workers and experts like the people on this program. So we've talked a lot about that there's all these pressing issues. The worldwide aging population is something I think about. Kelly brought up the issue with elderly patients. And again, who's to say that all these face-to-face visits were always 100% wonderful, either for the provider or the patient? So I think sometimes people tend to compare telehealth to like the ideal of a face-to-face versus the inevitable barriers. We've talked about rampant increase in healthcare costs. And I really am concerned about the pool of clinicians. I've been encouraged that in recent months, there's been a bump in people applying for all kinds of healthcare training programs. Public health schools have seen more applicants inspired by Dr. Fauci. Kelly and I have been talking about how medical school applications are up, and particularly people of color, which is fabulous. And yet, I know that there are a percentage of providers who have been through hell with this pandemic, and some of them maybe only privately are saying, when this is over, I'm changing careers, or I'm stepping back from direct patient care and using my skills and knowledge in other ways. So we have to prepare for more people needing care and more intensive care needs of an older population with perhaps less clinicians. And there definitely is a role for technology to play. This is a future vision for comprehensive care delivery. And just to make it more concrete, triage and intake, how people look up and select their doctor, financial navigation and transparency. I mean, all of this is pretty recent. Then care delivery with virtual and traditional modalities. Really big opportunities with automated reminders, smart wait lists. And I would add in here, even though it's not technically delivery of care, the fact that Uber and Lyft have healthcare divisions. And I don't know if you guys saw the headline, but Lyft, most of these services used to be business to business, where the medical practice would engage Lyft to say, hey, this person's had a history of being a no-show, or we know that they don't have a car or have transportation challenges, go get them. And it really positively impacted their no-show rate, and therefore their bottom line, because those gaps in the schedule were now being filled. And there's papers on it. You can look it up on their website, really good data collection and analysis. And Lyft just opened another service which can be initiated by the patient. So again, I don't know if it's talked about that much in medical school, where the idea is, of course, the patient's there for you. Now, what do you do with them? But all this stuff about getting the person to the appointment is a big deal and really undermines the effectiveness of our system. So then more ways for the patient to pay and more patient communication. I also want to emphasize for all of you who are already well-educated and getting more education, that this is what you think about all day. And when you're in your patient visit, you think maybe what you're saying is obvious. However, for the patient, they may not quite get it. They may have different learning styles. So the more we can have different ways of documenting what you found, what you want them to do medically, either with the care team or on their own, I think that will increase patient compliance, and therefore we'll get better outcomes for the time and money that we're spending of them engaging in the healthcare system. And then finally, home-based patient monitoring and engagement. I won't sort of bang the drum more, but I'm very interested in asynchronous. I think that comes back to the providers communicating with each other. And as I said, patient absorption of clinical instructions. And remember, a lot of people live in family situations where maybe they need help from their spouse. And if the two of them can look at the instructions or interact together with the provider, you're going to get probably a better patient engagement. And then the opportunities of multidisciplinary teams, and like I said, patient, family, and community.
I'd actually love to ask a question here, Professor Levitt, about asynchronous delivery of care. Whose responsibility is it to develop that content? Would you imagine a health system developing a series of videos on common health concerns? Because that we already have precedent for that in terms of follow-up instructions. Epic spits out instructions that we can just type in a dot phrase for and find, instructions for caring for your dizziness, right? Like those things are super common already. Is it on the EMR? Is it on Epic, Quest, you know, NPRS, etc.? Is it on the health system? Is it on the individual provider? Or is that super dependent on your practice environment?
Well, I think some of it depends on the practice environment. And, you know, that's a great point, Kelly, because I'm a Kaiser patient. And for a couple things, you know, Kaiser's had a pretty robust online system from the early days, and it helps that everything's all under one umbrella. You know, they have complete control over the facilities, the practitioners, and, you know, they have a unified electronic record, home build, basically. And I definitely received assigned videos for certain procedures or, you know, based on what they found about my health. I think, again, this comes back to having that a broader horizon that for you guys who are in training or just graduating as doctors, there should definitely be someone with a clinical background making those decisions. And it should be somebody who's at a high enough level of the organization that you can, you know, usually it's like a RFP, request for proposals, that you would look at different options, do a financial analysis, maybe not you personally, but someone in the organization would say, well, what does it cost for us to make our own videos? Is there something special that we're doing? What does it cost to buy from this vendor versus that vendor? And I would argue there's a piece around tailoring it too. And it maybe doesn't always have to be the doctor. I think we have a progress needs to be made in terms of protecting doctors practicing at the top of the license. But as we get, I mean, if you look at top careers for healthcare, there's a huge demand for medical assistants, physician assistants, nurse practitioners. So if we get to some coordinated team-based care, I think maybe, Kelly, the answer is that the medical practice or health hospital or health system buys access to a library of instructions, and maybe the nurse practitioner or the physician assistant is tailoring that as to like, when does it go to the patient, having a feedback loop, like as a professor for remote teaching. I mean, there are ways that you could ask knowledge checks of your patients. Did you understand this? Or tailor it to their situation.
Fair. Okay. I'm getting all kinds of ideas for a possible, you know, quality improvement project during residency. Hello.
Yeah, I think that's really important. And remember, for all of you, right, there's big generational differences. I mean, I think we're going to hit a watershed of more people in the workforce who grew up with, never mind computers, grew up with texting, grew up in the era of YouTube, that, you know, my undergraduate students vastly prefer to learn from video. And actually, a group project they do involves making video, and they are really good at it. So I think that it's also fascinating to me, the interactions of particularly physicians these days on TikTok. So with COVID, people were doing TikTok videos, trying to promote public health practices, et cetera. So there's a lot of modalities that can engage people even on serious, even with a serious sense of purpose. You can use a lighthearted approach that might be more accessible for many of your patients. And I mean, we've hit the point that most tech videos, like if my Microsoft software isn't working, often the video that helps me fix it doesn't even use English. Like it's just point and click, you know, go here, go there. It's showing me, which means anybody can use it. You don't have all these costs for translation. So I think there's a lot of opportunity, and I hope that the people in the audience will contribute your expertise. So we're really in the last couple of slides here. I'm very passionate about self-care, healthcare learning, and also this idea of prepping for sessions. So maybe encouraging people the patients to review some content in advance if they're under care for a chronic disease, et cetera. Opportunity for the provider to take a look at, oh, what's been going on with my patient for the last 3 months? Here's a report that synthesizes that data for me. I think, again, if we're down to such short office visits, that would make better use of the time. We just have to look at the overall compensation model to be fair to the providers, who many of whom are frustrated with medical records already taking up a lot of their pajama time at night for documentation. A lot of opportunity with reimbursement. I have alluded to value-based care. I think there's better ways to account for the provider's time. And also, I think there'll be opportunities to better measure where are providers having impact. And I still want to just raise the flag as a non-clinician that please stay curious as a provider, because the things that you may think are making the difference for your patient may be different than their own experience. And finding ways to capture that feedback. You can't always ask them directly, maybe someone else on your care team, or data shows that you often get better, more honest results if someone is filling it out on an iPad while they're waiting for the visit, or they do a follow-up survey. And I just really believe in making the interactions relevant between the care team and the patient. I also am really intrigued by more personality types and communication styles. I still maintain that there are people who are very intimidated by medical buildings, either culturally, education levels, et cetera. A lot of interesting data coming out about role of online chat. So for someone who's not very verbal, doesn't process information very quickly, or just is worried about a diagnosis possibility, or just heard bad news, they're not really going to track with you while the provider is talking about something that they have studied extensively. So there's a lot of options with online chat that I think are exciting. And also on sensitive topics such as behavioral health, sexuality, similar as some of the bad side of the internet, that people will say more when they feel safe behind a screen that may not be polite or considerate. They also might give you better, broader information about their health that they either don't know how to bring up, or they are shy to answer those questions. Some other themes around social determinants of health: racism, variations in language, education, culture, and what does it mean if someone could initiate care from a provider and nobody knows what the other person's race is? What about all the unconscious bias that's been going on that might be filtered out for preliminary intake, et cetera? And I'm not saying keep people anonymous or fake, but that might be a different layer for a problem that has plagued the health system. We talked about various types of intimidation, and also better access to finding a good match if you don't have geographic barriers. So if somebody really would benefit from a provider that matches their ethnic group, or similar lifestyle or upbringing, et cetera, that you can get that tailored. And you really do see that on services like BetterHelp and Talkspace, et cetera, that especially for mental health, the matching is really key. So here comes resources, and tons of websites, people on LinkedIn, newsletters, webinars, conferences. These are websites for industry associations. Your local state probably has websites about local digital health. There's something called telehealth resource centers that are regional. They offer customized consulting, often free or low cost, funded by government grants, and also hold conferences. These are some of my favorite thought leaders. And there was another piece here that didn't seem to save properly. Let's see. Oh, there we go. These are additional thought leaders. And something that has really given me ongoing inspiration and camaraderie is called a tweet chat. And it's open to the general public. Encourage you to check it out. Wednesdays, usually I think every other week now, 5 to 6 p.m. Pacific. Follow hashtag #TelemedNow. And I mean, there are some really high-level people, industry pioneers. So not only Jamie Edwards, who's the CEO of a telehealth platform, but former presidents of American Telemedicine Association, leaders of the American Association of Community Health Plans, et cetera. So there's designated questions to discuss. It's pretty structured. It moves at a fast pace. People are very good humored, very welcoming. And so that's a nice way to find out more about what's going on. And I hope that you will reach out and say hello on social media. You can find me on LinkedIn and Twitter. So I made it with a little over 10 minutes in case there are any other questions that people want to either message me directly or send to the group or send to our facilitator.
Well, thank you for this. You gave us some really good definitions so that we can clearly define what people mean and what we mean when we're talking about telehealth, telemedicine, digital health. They're related, but not necessarily synonymous. So I think it's good for us to have that vocabulary, especially because everyone in this room has some sort of vested interest in healthcare. Whether you are a current provider, a future provider, this is going to affect you, period. The pandemic thrust us into this discussion in ways that I don't think a lot of people were ready, but I think a lot of this is here to stay. We've seen too many benefits in terms of access specifically, and that was one of the biggest talking points here. And there's just too much money to be made, quite frankly, in this industry for this to disappear. So I think it's necessary for us to have this context if we're to be true advocates. Again, it comes down to us understanding the full scope of issues at hand, understanding all the tools that are available to us to be effective advocates. So I thank you for being with us today, Professor Levitt, and giving us this insight.
Sure. I mean, I am really intrigued by, at this stage of my career, medical education and how people are getting trained and how it shapes their expectations of what it's going to be like to be employed in the healthcare system. And I mean, I tell my students all the time that we need new solutions, basically. So I mean, that's why I really applaud the efforts of the people who put together this wonderful series of presentations. And I guess I view my role partly as leading from my base of experience, but also kind of giving more support to people who are going to bring solutions that I would never have even thought of, because you guys have a completely different context in terms of your technology toolbox, in terms of communication styles, life experience. And I mean, I feel like despite a lot of good efforts from providers, the health system was designed for a world that doesn't exist anymore. So it's kind of hard. I think some of the people personalize that mismatch. And I think part of provider burnout is very dedicated, high achieving people not being able to practice medicine in a way that's satisfying and feeling like I'm doing something wrong. I can't fix this. I got to leave. And there goes, 10 years of their life and hundreds of thousands of dollars. So, that's kind of my call to action for all of you involved in this program to help. It's a big ship, but like turning the health system slowly in some better directions.
I think that was quite the sermon there. The idea of there being incongruence between the idea of how medicine should be practiced and the reality of how it can be practiced today. That's a word. So I do want to open the floor for questions for folks. We do have a couple minutes. I will ask for the formally registered students or those that are participating in our debate activity to stay on for sure. But I do want to open the floor for questions should people have them. And regardless, if we do get any questions from our audience, I think you just explained things really well, so people weren't left in the dust. I didn't have to clarify much either, but I want us to be aware of this debate and know that it's a continuing discussion. And I hope that you'll continue to join us in the Advanced Health Policy elective. So we appreciate you, Professor Levitt.
Thank you. Thank you so much. I put a little more in the chat in terms of my directly how to reach me on LinkedIn. And also, I'm just fascinated by Twitter. I'm pretty recent to getting involved, only about a year and a half or so. But it is, not surprisingly, a lot of digital focused people are hanging out on Twitter. And as you said, Kelly, so well, discussion of digital health is really prominent just out of the necessity of what's going on. So Twitter is a really interesting place to find people with similar interests, hear hopefully different perspectives. I definitely encourage you to follow people who are different from you and maybe not get stuck in a bubble of, hey, everybody thinks like me, because everybody on Twitter says the same things as me. So trying to branch out a little bit more. I mean, there's a pretty good tradition of following back. I personally, one of my role models I found on Twitter, Joke Vedar, who now heads we overlapped at Mass General Hospital, and he now heads the American Telemed Association. I followed him on Twitter and he followed me back, and I was so excited. So, I mean, it's actually relatively easy to engage people who a decade or two ago would have been so, kind of behind a wall of elevated positions or geographic barriers. So, and Clubhouse too, I have not gotten involved there, but there's a number, I should have added that to a slide, but there's a number of digital health focused discussions on Clubhouse.